Good morning, ladies and gentlemen, Mr. Chairman. I came from Poland. I'm from ENT, scalp-based surgery department of Medical University of Białystok. And my talk will be about something different than rhinoplasty, but I hope I will not bore you to death and you will find something interesting in what I'm going to say. I'm going to talk about endoscopic surgery of the orbit. There are numerous ways of approaching the orbit endoscopically. We have three main types of approach: transnasal, anterior, and lateral. These are most commonly used: transethmoidal approach and transmaxillary approach. But as you can see, these marked in the red color are typically used. Others are used very rarely in very specialized centers. Why there are so many ways to approach the orbit? This is because the main rule in endoscopic or microscopic surgery of the orbit is never cross the optic nerve. So we are supposed to choose the shortest way to approach the lesion inside the orbit, trying not to cross the plane of the optic nerve. If we go transnasally is the most natural way to approach the orbit endoscopically. We can go both through lamina papyracea, through ethmoidal labyrinth, or through inferior wall of the orbit, through antrostomy. Laterally, we approach with modified endoscopic approach, with a modification of neurosurgical approach, crane-line approach. And externally, we can go directly transorbitally or transmaxillary through canine fossa. When we choose transmaxillary approach, we should be aware of the fact that using this simple approach through natural ostium or enlarged antrostomy, we can see barely one third of the orbital floor. So it's more wise to choose one of these anterior approaches, either through canine fossa or through so-called prelacrimal approach, just between nasolacrimal duct and anterior maxillary wall. There are some examples of these approaches. This direct transantral approach, using 30-degree endoscope, we barely see the side of the lesion, so we have chosen transcanine fossa approach. Using 0-degree optic, we can easily open the orbit, and in this particular case, we found a splinter, bony splinter here, which is not surprising to us. It's foreign body sometimes causing growth of inflammatory tumor inside the orbit. This is the deficit we created in the anterior maxillary wall, and this is the deficit that was created in the inferior wall of the orbit. This another example of transnasal approach. When we go transnasally through unilateral nostril, it's sometimes awkward to reach more laterally. That is why to improve angle of approach, we go transeptally, creating 3 incisions separated by the distance of 1 centimeter. So one is first is made in contralateral nostril, then through the septum and through the unilateral nostril, and then we can reach far beyond the infraorbital nerve, so much more laterally. We incise the periorbit. We can work by manually or with forehand technique with assistant. So 2 hands are free to manipulate inside the orbit. We can remove easily the tumor, which are not solid, which are semi-fluent. It's post-operative view of this patient. Some other lesions. When we've got extraconal lesions, so lesions located outside the muscular cone of the orbit, like hematomas, cystic lesion, or abscesses, It's quite easy to access because after removal of lamina papyracea, we get full access to the lesion, and pulling it gently, we can dissect the cyst from the surrounding tissue of the orbit. If there are fluid or semi-fluid lesions, we always perform ultrasonography at the end of the operation to confirm that the whole lesion was removed, because sometimes we have sort of patches, separate patches of fluid, and they are supposed to be resected at the same procedure. Another extraconal lesion, this is a wooden splinter here in the orbital apex, just at the junction between posterior ethmoid and sphenoid sinus. After removal of the bone, with a drill, we incise the periorbit, and we see the tip of the splinter, which can be removed without further manipulation inside the orbital cone. After removal of the splinter, it's quite a big splinter actually, and we can see the optic nerve here, optic nerve at the tip of the orbital apex. Much more difficult to explore and to dissect, or to even to take a biopsy, are intraconal lesions, so located inside the orbital cone, just between these extraocular muscles. Usually we choose this route of approach between middle rectus muscle and inferior rectus muscle. It's most convenient. Sometimes if you want to go more laterally, we can go just laterally to the inferior rectus muscle. This route is supposed to be avoided because when we enter the intraconal space, we go directly at orbital vessels. Another example of such operations. Lamina papyracea is removed. We incise the periorbit. As you can see, this lesion occupies retrobulbar space, so the fat first have to be removed to expose orbital muscles. This middle orbital muscle, this is inferior straight orbital muscle, and the tumor is here, just between these two muscles. The space between these two muscles is quite big. In immediate post-globular side, I mean, most anteriorly, this space is pretty vast, pretty huge. So the tumor can be easily grasped, dissected, or biopsized. But when we go more posteriorly, these muscles come close to each other, and there is hardly any space between them in the orbital apex. So when we have such lesion here, like in this case, this meningioma of the optic nerve. Sorry for the quality of these pictures, but when I want you to show that these muscles at the orbital apex are very close to each other, and there is no space between them. So when we operate, we're supposed to have an assistant or another surgeon to keep these muscles separated, and then we can use other hands and other instruments to dissect the tumor. Now a few words about external approaches, endoscopic approaches. There are 5 of them, and I will discuss them in details later on. First, ergonomics. The position of the surgeons during such operations is quite different than in regular FAS procedures. We use holders for the endoscope to stabilize the view, and spatula to create a tiny, small corridor between orbital tissue, because otherwise the tissue will collapse into the operative field and obscure the vision. Transconjunctival approach. We create a small incision along the cornea and insert the endoscope, separating the tumor first from the eye globe and extraocular muscles, and then externally from the bone of the orbit. When it's separated, it can be pulled outside and cut off externally. this pre-operative and post-operative view of these cases. Another quite interesting example of this approach is metallic foreign body, which just went through the eye globe and was fixed close to the posterior wall of the eye globe. This orbitoscopy, you see the fragment, metallic fragment, moves when the eye globe is moving. It's the same transconjunctival approach. This is the eye globe, ruptured eye globe here. This angled 45-degree optical nerve here. We use the magnet. This is the magnet, and this foreign body was removed this way. Then the ruptured eye globe was sealed, and we sutured the incision. There are two approaches through superior or lower eyelid, very similar to microscopic approaches, but the corridor is more narrow. We use them to approach more anteriorly located lesions. In this case, this is a metastatic lesion of the superior wall of the orbit, extracondyl. For lateral lesions of the orbit, we use either retrocanthal approach or lateral modified endoscopic approach. The incision is created posteriorly to the lateral canthal tendon. Again, we separate first the tumor from the orbital tissue, then from the orbital wall. In this case, we used also ultrasonic aspirator, where it's safe. I mean, where it's at some distance from neural tissue, from optic nerve, we can use ultrasonic aspirators. And we remove the tumor, create hemostasis, and suture the wound. One more approach is a combined approach. What is interesting in this case is that this tumor can be easily accessed transnasally, but transnasally would have a problem to dissect the tumor from optical nerve. That is why we have chosen combined approach. First, we go externally to the tumor and separate this fragment of the tumor from the optic nerve. Then the tumor could be resected easily, either through the nose or through the same incision, external incision. Well, we always take these muscles on a string, so we can differentiate between tumor tissue and muscular tissue. The last approach I want to show you is lateral endoscopic approach, is modification of neurosurgical approach. Neurosurgical microscopic approach is a cranline approach. As you can see here, this entire bone is removed during microscopy to facilitate visualization with the microscope. So this bone along the rim of the orbit is removed during such surgery. In endoscopic view modification, we create a narrow tunnel that enables us to insert the endoscope along the posterior wall of the orbit. We can go to the orbital tip as well. We can look more anteriorly. We can use also angled optic to look at the eye globe. The incision of the skin is horizontal to hide the possible scar in the wrinkles. Then we separate the muscle. This is the case. Tumor is located in inferior and posterior part of the orbit. Incision. Then we separate the muscle from zygomatic bone and temporal bone. We use neuro-navigation to find where the tumor is located in the orbit. Create a hole in the greater sphenoid wing. And then we separate the tumor from the surrounding tissue, pull it out. Reconstruction of the wall of the orbit is not necessary. In this case, we sometimes put a patch of Tahoe seal on the wound and fill the gap with a muscle, temporalis muscle. This post-operative view and deficit in this particular case. And to conclude, the huge number of approaches to the orbit result from, result from the rule that we are not supposed to cross optic nerve, and procedures are technically demanding. I mean, it necessitates some experience in orbital surgery as well, as well as quite good equipment. And we see potential for future development of orbital and transorbital endoscopic intervention thanks to ongoing progress in technology. Thank you very much for your attention.
Thank you. Thank you. Do you have any question, please?
So, thank you very much for your excellent lecture. I have a few questions. I do endoscopic, say, medial orbital decompressions in India. I am Dr. Chandra. So I have seen a case in a 5-year-old child. We did medial endoscopic. Say, it was an optic nerve glioma, encircling the whole of the optic nerve on all the sides. We exposed the tumor from the, say, endoscopic nasal approach. We removed the medial wall and visualized the tumor. And it was encircling the whole of the optic nerve. And our senior asked us to again consult with the patient's family members and attendants regarding the prospect or prognosis of a vision loss later on after post-operatively. So the patient's attendants refused to go ahead with the removal of the tumor after exposure, and we stopped it. So how will you approach these kinds of cases?
Well, transnasally we are able only to dissect the tumor medially, right? So in some case, we can go externally with this last approach I mentioned, to go to the optical nerve laterally. But it's sometimes very difficult because of type of the tumor. Glioma or meningioma of the optic nerve are very difficult to dissect from the nerve without injury of the nerve. So I can consider the fact that blindness is possible after such operation.
Thank you.
Thank you.
I have one more question, please. What is the best and the quickest approach when we have an orbital hematoma?
Well, it depends on the location first, and usually hematoma forms between the bone and periosteum, right? So it's actually not intraorbital, it's extraorbital. It's between the bone and the periosteum. So the quickest way, if it's located medially, is trans-ethmoidal approach, right? Very rarely it is located inferiorly. But if it's intraorbitally, it's much more difficult, especially if it goes into the cone. In such case, we have to penetrate the orbital cone, and it's difficult to visualize the cave of the hematoma. So we can insert the curved suction tip, we can manipulate, suck out the fluid, but we are never sure that we removed everything. That is why we use intraoperative ultrasonography to confirm the whole fluid was removed. Yeah, the other advantage of ultrasonography is that when we insert something in the orbit, we move the soft tissue aside, right? And we cannot confirm it using, for example, neuronavigation system, because made preoperatively, right? The image is created preoperatively. So when we insert and we have shift of the tissue, the neuronavigation is not accurate anymore. So we use intraoperative ultrasonography to confirm the movement of the tissue inside the orbit, and sometimes we can even see the tip of our suction. Thank you.
Thank you very much.